I'm going to start the webinar today with our land acknowledgement. The Office of the College of Midwives of Ontario is situated on the traditional and current territories of the Anishinaabewaki, the Wendake, the Haudenosaunee, and the Mississaugas, including the Mississaugas of the Credit First Nation, and is covered by Treaty 13 with the Mississaugas of the Credit First Nation. As a provincial regulator whose mandate extends across Ontario, we also acknowledge that our work takes place on diverse and distinct Indigenous territories and treaty lands throughout the province. With gratitude, the College recognizes the Indigenous communities who have stewarded these lands since time immemorial and honors the work and legacies of Indigenous midwives. We are committed to respecting the unique and cultural spiritual relationships Indigenous peoples hold with the land and with the waters, and to supporting Indigenous sovereignty and the calls to action of the Truth and Reconciliation Commission of Canada. So, a friendly reintroduction to the professional standards for all of us. I know that you're all probably reading them every single day and just delighting in their content, but for those of you who maybe haven't looked at them in a couple of weeks, the professional standards for midwives, which we call the professional standards, describe what is expected of all midwives with the college, which is registered with the College of Midwives of Ontario, which we call the college. The professional standards set out the college's minimum requirements regarding your practice and conduct and helps you achieve the best outcomes for your clients and the public. So, as you know, the standards are divided into 5 essential principles. Those include professional knowledge and practice, person-centered care, leadership and collaboration, integrity, commitment to self-regulation, and there are also professional standards which are specifically required for midwives who are also practice owners within each of these categories. We review all of the professional standards, not just the professional standards that you see here today, but any other professional standards on a schedule, or if there is a requirement based on changing landscape or emerging trends. The review follows a specific methodology where each standard is assessed for clarity, effectiveness, reasonableness, and proportionality. Typically, this happens every 4 years. So after the last version of the standards came into effect in 2021, the review was completed in 2025. And in April of this year, the Quality Assurance Committee of the Board of Directors of the CMO was presented with the findings of the comprehensive review and approved the college's recommendation to proceed to public consultation on several current standards and some proposed additions. And we're going to get to that. So, how do we review the professional standards? Let's get into some of the steps that are taken. So the college actually has several years of data that we can mine and analyze. This data comes from professional practice, professional conduct, and through any other interactions between members of the public and the college and midwives in the college. So when members of the college are reaching out and asking us questions about standards, we're actually keeping track of those conversations. And the same thing goes for midwives. And, of course, this information provides us with a large amount of data to be able to take a look at to understand whether or not there are certain standards that are showing up disproportionately within the practice advisory service or potentially within the conduct and complaints department. So it's a really great resource for us to have to start having these conversations about whether or not the standards are meeting their aims of public protection. We also had meetings and consultations with various counterparts across the regulation sector. So other colleges like the College of Physicians and Surgeons, the College of Speech Language Pathologists, the College of Physiotherapists, et cetera, where we discussed some of the clarity of our existing standards, possible alternatives that have worked well in other jurisdictions that may work well for us. And we've asked about some enforceability and minimum thresholds from colleges who have already implemented changes like the ones that we are considering. Finally, we engaged the Citizens Advisory Committee to receive specific feedback on health equity standards. After that, we drafted and in some cases redrafted and possibly redrafted the redraft of the professional standards that were identified for revision, and we developed some new standards in areas where necessary. And as you saw on the last slide, we have 14 professional standards identified for revision at this time or rewrite, and there are 6 new standards proposed. And so without further ado, I bring you the proposed professional standards for midwives for 2026. So I'm going to go through the different professional standards. I know that you have access to these if you've taken a look at our public consultation materials. And, So that we can make the best of our time together today, I'm not going to read out the standard and the recommendation and just kind of flip through the slides. I'm actually going to provide you with the rationale for why the recommendation exists. So for example, standard number 5, this standard was identified as part of a plain language review, and it was revised to be more clear. The record keeping standard, which is a standalone, sets required actions to meet standards for documentation. Professional standards, as in standard number 5, by comparison, addresses broader expectations for client safety as opposed to specific documentation and record keeping requirements. We recommend the revised standard to avoid system failures, which may impact client care. For standard number 7, this revision reflects a minor wording change that better encompasses related but distinct actions, and I'll explain what I mean by that. So, since the Designated Drugs and Substances Regulation was updated in 2024, midwives may now perform tests in addition to ordering and interpreting tests. So, any of those point of care tests that were not previously included in our Designated Drugs and Substances Act regulation, which now appear in the Designated Drugs and Substances Regulation, we wanted to make sure that the standard included them as well. So you can see that the language has changed slightly to include performing and interpreting tests, not just ordering. The recommended revision also includes another step for plain language, and we recognize that there was a lot of material in the first standard, and it talked not just about prescribing and administering medications, but we were also talking about lab tests, and we were kind of jumbling them up, even though those are two distinct aspects of midwifery care, often hand in hand, but not exactly the same thing. So to simplify the standard, we've recommended that the revision distinguishes between these two actions related to tests versus those related to drugs and substances. So you would see a renumbering here. So instead of just having standard 7, it would become standards 7 and 8. Going forward, just for everybody's awareness, you might not see the standards that we're looking at renumbered based on this. Like they don't necessarily start, like the next standard is not 9. The next standard, if you looked at the professional standards today, would still say 8. So if we're moving forward and you're like, well, wait a minute, is this 11 or is this 12? We're sticking with a standard by standard approach. And so you can see that at the outcome of the final consultation, all of the revised standards will be, numbered sequentially, in case you were losing sleep about that. Okay, so moving on to standard number 9. From our internal data, we noticed that midwives often seek practice advice about how to achieve this standard. Quality assurance outside of our quality assurance program, the Friendly Professional Development Portfolio, which we all know and love, it's not always immediately obvious, and sometimes there's some a lack of distinction between those two expectations from the college. So if midwives are unclear about a college expectation for quality improvement, then these activities might not necessarily be integrated into routine midwifery practice as the college would expect. So though midwifery practice owners have a standard to provide the resources to support this standard, it's important to be clear about activities and specific actions that all midwives are expected to take to meet college expectations and support safe and effective client care beyond your requirements for the professional development portfolio and other aspects of the quality assurance program. Okay, just gonna hydrate for a second. Okay, so standard 12. The original standard was reviewed for clarity in plain language. The term quality improvement systems was identified as jargon. It doesn't mean the same thing to everybody, and it might be difficult to implement a standard if you don't necessarily understand the key terms. So that poses a potential risk. So lack of clarity of the desired outcome can lead to some ineffective implementation, as I noted, and so the revision is simplified and a little bit clearer. For professional standard 13, reported trends from professional practice and conduct reflect some misunderstanding of the standard as it's written today, especially if, and let's be honest, when a midwife might miss a precipitous birth in the role of second. This happens, and the standard can be misinterpreted as a guarantee that there will always be 2 midwives or 2 healthcare providers or a midwife and a second birth attendant in attendance at every midwifery-led birth, which may not be possible in a variety of circumstances. This sets an unattainable standard in some situations, and so the revision manages expectations both for clients and for midwives. So standard number 14 is more about listening and communicating information. We recognize that the midwifery client can only make decisions about their care when they know and understand the factors at hand. And there's lots of different ways of knowing. Midwives can possess some knowledge and experience which the client may not already have. And so the onus is then on the midwife to translate their knowledge and judgment to the client in order to provide effective health care. The original standard just assumes that the information is understood. So you're listening to clients, but there's a piece that we identified as missing here. The revised standard takes meaningful steps to include that those at risk of being harmed by failure to meet information sharing best practices are still protected. And the listening portion of the original was highlighted as critical because sometimes it can be overshadowed by that emphasis on information delivery. So there was an important step here that we felt could be more effectively managed by chunking out the recommended revisions, the way that you see them written here, and creating a new standard. So by renumbering the standard, adding a new standard, and by making the proposed revision, we amplify the importance of listening and clarify expectations. Right. Oh, good. We're right on time. 15 minutes of me talking straight. You're all doing great. So in the case of professional standard 15, the revised standard better supports client autonomy by recognizing clients as the people who make the decisions about their own health and the health of their newborns. It clarifies that midwives must understand and respect what matters to clients, including their values, preferences, and lived experience, rather than just assuming participation alone is sufficient. This is especially important for clients who face power imbalances or barriers to having their priorities heard, including marginalized, racialized, and Indigenous clients, and clients from religious and cultural backgrounds. The revision strengthens person-centered care and reduces the risk of harm from care that does not center the client and the client's choices and priorities. So standards 16.1 and 16.3 are often at the heart of complaints, communication breakdown, and the root cause analysis of poor outcomes. We've been hearing this from High Rock a lot. Communication is pretty important. And I don't want to understate that. It's probably one of the most important. So, as you know, informed choice as a part of our communication is a multi-step process, and it includes providing information in ways that clients can understand, listening to clients' perspectives and understanding their values on the matter at hand, engaging in a two-way dialogue that ensures understanding that is shared between the client and the midwife, client-led decision making. And training in effective informed choice decision making is a keystone of midwifery education and ongoing clinical practice. This is why we have a standard and all of the substandards that exist under Standard 16 that are just so extensive on this topic. The safe delivery of an informed choice discussion occurs as a dialogue. Failure to appreciate this sets unclear expectations of the depth of communication required for a fulsome informed choice discussion. And it also can create some gaps in documentation of material communications. So we recommend these minor revisions to enhance midwives' understanding of the college's expectations and clarify those expectations for clients. This one's a bit of a more simple one. It's not too technical. Employing a reasonable and transparent client intake process is the critical action that midwives have to take in order to meet this standard. We conducted a plain language review of this standard, and we recognize that the term develop may not actually describe the intended outcome of this standard accurately. We expect that midwives employ a process, not just develop it and put it on a shelf, but it actually needs to be used. So that's the change for standard 22. Standard 33, never abandon a client in labor. So clients are impacted by the standard when the definition of abandonment is misinterpreted or misunderstood. Midwives are impacted by this standard as well, especially when it pertains to clarifying the difference between a planned and reasonable transfer of care versus the true definition of client abandonment. The revision is direct and it explains the college's expectations clearly for both clients and midwives and provides more definition. Standard 34, the standard extends the expectations of the college for midwives in their professional dealings, in particular with the college. The revision holds midwives to professionalism in all communications and interactions with their regulator. So it's a minor revision, but an important one. Professional Standard 45. Though well-intentioned, this standard may set an undefinable threshold. Words like well-being can be problematic. On one hand, laws exist to protect workers against bullying, harassment, and discrimination in the workplace and go well beyond the college's mandate of public protection. They supersede the college. Within practices, we know that issues can arise due to unresolved conflicts, business management practices, be they fair or unfair, depending on the circumstance, and the impact of broader system inequities. The current standard is problematic as well because the ability of the college to regulate business practices, which impact worker physical and mental health, is often limited to issues of professional misconduct and those decisions, actions, behaviors which rise to the threshold of breaking the law. As such, those day-to-day inequities, those day-to-day conflicts, microaggressions, failures on the part of the practice owner to apply fair management practices, and straight up personality conflicts, which can all escalate to the point of negatively impacting client care, may be outside of the purview of the college. And so we recognize that failure to address these systems negatively impacts midwives and leads to a reduction in client safety. The bottom line is that the problems can still persist and the college is limited in how we can address them. So it becomes difficult to enforce this standard as it's currently written. The revised standard directly addresses the college's expectations of practice owners to develop and implement client safety standards within the midwifery practice environment to protect the public from harm. So it is a reframing of Standard 45 that centers client safety in the systems that need to be established by practice owners so that issues like some of the issues that I described earlier are addressed, identified, and resolved so that they do not impact the environment in which the midwifery care is being provided and, by extension, the health and safety of midwifery clients. So again, number 53, employing a system to deal with client complaints is really the critical action for this. And following a plain language review, we recognize that the term established may not actually describe the intended outcome of the standard. So we expect that midwives employ as opposed to establish. All right, so now we're going to move into some new territory and talk about the 6 new standards which we are recommending to promote health equity. As many of you already know, equity in healthcare means providing care that recognizes and responds to people's different needs and circumstances. This principle builds on person-centered care by recognizing and acknowledging that midwifery clients face ongoing barriers to care and discrimination within the healthcare system. Midwives are expected to provide care in a way that addresses these barriers and discrimination. Barriers and discrimination disproportionately impact people who are First Nations, Inuit and Métis, Black and or racialized, people who are 2SL, LGBTQIA+, low-resourced, newcomers, and include people across various religions, ages, and abilities. And this is especially important when considering the intersectionality of these various aspects of humanness. Following a literature review of current research and recommendations in regulatory excellence and best practice, and an environmental scan of other health regulators across the country and beyond, we determined that there's a need to add a new mandatory principle called promoting health equity. And under that principle, we are recommending 6 related standards. Now, we recognize that midwives work in and against systems of oppression in their daily practice. We also recognize that it is unreasonable to expect midwives to resolve these systems completely or fix societal problems on their own. Now, I'm going to say that again because I know that there is a deep desire in all of us to address these issues, and certainly amongst midwives in particular, a desire to do it right. But the college recognizes that you have a particular sphere of influence, and it is unreasonable to expect midwives to completely resolve these systems or fix societal problems on their own. I want you to bear that in mind when you're taking a look at these recommended professional standards related to promoting health equity. Because let's be honest, midwives are expected to understand biases and assumptions that exist, including their own. Midwives are expected to recognize the impacts of social determinants of health and take steps to identify, address, and prevent systems and symptoms of oppression as they relate to the provision of midwifery care when they observe them. Right now, we know that midwives are already meeting these standards in their day-to-day work. So without even being written, we know that midwives are doing this work already, and they're doing it very, very well. They are addressing health equity to make care safer for their clients. Midwives can continue to contribute to safer healthcare experiences by providing inclusive care, being aware of the power and privilege that exists in the provision of healthcare, and taking steps to provide trauma-informed care consistently. Of note, the structure of these standards is intentional, and it's based on 6 core concepts that were identified in the literature that was published by our colleagues at the BC College of Nurses and Midwives. The 6 core concepts that they identified are self-reflective practice, building knowledge through education, anti-racist practice, creating safe healthcare experiences, person-led relational care, and strength-based and trauma-informed practice. So without further ado, I'm going to read the professional standards to you, and then we're going to shift gears a little bit and talk about each standard on its own through the lens of a case study. And I'll be able to talk about that after I read these ones out to you. So number 56, and forgive me, I have to do this because they're on my big screen. Reflect on equity and inclusion practices and implement ways to incorporate them into the care that you provide. So that's the self-reflective practice. Learn about cultural humility, Indigenous cultural safety, anti-racism, and bias in healthcare on an ongoing basis. That's building knowledge through education. 58 is demonstrate cultural humility and inclusivity principles in the care that you provide. 59 is understanding how power, privilege, and social determinants impact your client's health and make reasonable efforts to accommodate safe care. 60 is demonstrate welcoming, inclusive, and culturally safe practices in all aspects of care. And number 61 is care for clients who face inequities in ways that remove barriers and support choice. So moving on, let's get started at the beginning. And here's the structure of this part of the presentation is really to get into some examples of where you might see these standards impacting your regular practice. Most of these case studies have come from real life scenarios with a little bit of zhuzhing up on my part, just to kind of get you used to the idea of where we're going with this and where it might show up in your practice. This first one is about reflection. It's a core part of the process of promoting health equity is just understanding gaps in your own knowledge and being curious about what you can learn. So as a case study, you work in a community health clinic, which serves a diverse population of urban residents. You feel that your knowledge and awareness of Indigenous cultural safety principles may be out of date. You know that you will be the primary care provider for clients who are Indigenous. So often the question that we are asked is, well, how do you enforce these standards? How can I demonstrate meeting this standard? Do I have to sit and, tell people what I'm thinking all the time? Not necessarily, but there are ways to demonstrate that you're meeting the standard. Number one is reflecting on and identifying gaps in your knowledge, taking that deliberate step to consider what you may not know. Seeking out education opportunities and completing some courses, reading, taking advantage of webinars, whatever is out there for you that you believe can close some of those gaps that you've identified. And of course, not to put in a plug for our quality assurance program, but you can set learning goals and complete activities in this area for your professional development portfolio. Moving on, talking about learning about cultural humility, Indigenous cultural safety, anti-racism, and bias in healthcare on an ongoing basis. So now we're leveling up. We're taking proactive steps to improve health equity for clients by learning. So here's an example. You have a client who comes into care for their third pregnancy. She explains to you that she experienced trauma in her last labor and birth, which she believes was a result of racist assumptions that her care providers made about her. She was told early labor that she was being dramatic and that she should be better at tolerating pain given her background. When she advocated for herself and pushed for an epidural, her provider noted in her chart that she was becoming hostile. Awesome. So, formal learning and informal learning both have a place here. Midwives who meet the standard can demonstrate the following actions: taking time to listen to what your client is telling you and identifying the origins of the experience. The client said to you, I believe that I was treated differently as a result of racism. Something really important to appreciate. Appreciating the honesty of your client's account and respecting their report as the truth. Accessing education on anti-Black racism, in this case, and understanding how it shows up in the healthcare space, and sharing what you know, possibly through peer reviews or maybe creating learning opportunities for your students. So again, we're going to move a step beyond. And as I said before, these standards build on each other, and they move from sort of individualized activities to proactive actions, and then towards more interactive behaviors that include possibly your clients on a one-to-one basis or making broader systemic changes. And you may feel that there is some overlap here, like, well, the first one's about reflecting, but we talked about learning. And I think that that's the nature of health equity. There's intersection of a variety of these concepts. And in real life, you're probably going to need to meet several of these standards in a single situation. So you may run into a situation where several of these standards are going to be applicable. And that's the name of the game for all standards. So, demonstrating cultural humility and inclusivity principles in the care that you provide. Your client informs you that next month she will be fasting for Ramadan. You, admittedly, don't know much about this practice, but the idea of fasting during pregnancy makes you uneasy. You're worried that this practice may be harmful to your client or her fetus. So, how could a midwife demonstrate meeting this standard? And they can demonstrate meeting the standard quite simply learning about that client's specific cultural and religious practices, respecting that client's autonomy over their own bodies and choices, not using your bias to push something on the client that they clearly do not want, providing information about nutrition in a non-judgmental and respectful way, and discussing with your client different ways to manage blood sugar while fasting. Now, I'm just going to take a pause here, and I think that this will also be relevant as we go forward for the next set of health equity standards. Sometimes it is helpful, you might find it so, to consider how a midwife would fail to demonstrate these meeting these standards. And I believe that in many cases, those actions that, for example, in this case, where maybe you refuse to learn about cultural and religious practices, or you do not respect the client's autonomy, or you don't provide care in a non-judgmental and respectful way, those are the situations where the college winds up hearing from the client. But if you are providing midwifery care in a person-centered way and you're positioning the client as the ultimate decision maker in their care, and you're recognizing and understanding how their religious or cultural background is impacting their decisions, you're meeting that standard. It is complex, but in so many situations, it's not as complicated as it needs to be. So let's get into, a little bit more of a heavy standard. So this standard is about relational care. And we're going to see a demonstration of expertise at this level in health equity promotion. Relational care is what we're talking about here. And relational care is defined as being relevant in those systems of inequality based on power and privilege. So the standard is written as understanding how power, privilege, and social determinants impact your client's health and making reasonable efforts to accommodate safe care. So our example here is your practice has implemented a new booking policy that features a fully online service for scheduling appointments and home visits. Very snazzy. Your clients log into an online portal using their phone or laptop and can book appointments based on their midwife's availability or join a wait list. You implemented this system to save on administrative costs and for ease of booking and canceling for your clients. Good on you. But one of your clients is currently living unhoused. She doesn't have access to a smartphone or a laptop, and her family lives in another city. They're not really in the picture, and she doesn't have local supports because she's estranged from a violent partner and does not wish to be reachable for her safety. So again, if you think about it from what I said earlier, saying to the client, well, rules is rules. Sorry, you're just going to have to figure out a way to work with our new system, may fail to meet this standard. Ways that you could demonstrate that you meet this standard include reflecting on the lived experience of someone who is unhoused and has minimal access to technology with a history of intimate partner violence. Speaking with your client about the booking system to see whether there is a way it can work for them. Is there a workaround? Could something work and make it as easy with your intention of making this a bit of a user-friendly system, or is it just going to make things harder for them? And then the last option, which is pretty clear, is employ an alternative to the booking system for a client who doesn't have that kind of access to tech. Those would all meet the standard here. So again, demonstrating a welcoming, inclusive, and culturally safe practices in all aspects of care. Your client reports a terrible experience with their stay in hospital on the postpartum unit. The nurse that was assigned to their care repeatedly used incorrect pronouns. The client identifies as they, them, and used the terminology breast instead of chest feeding, and referred to the client's partner as dad, despite being asked not to more than once. So, again, I'm going to take a step back and remind everybody about that sphere of influence. It is not always possible to have a life-affirming conversation with a colleague where they change their ways and, thank you for showing them their errors and move forward in an inclusive and welcoming way. And that is not the expectation. If we're thinking about it from the flip side, doing nothing in this situation would fail to meet the standard, or brushing these concerns off as, oh, that nurse is just old-fashioned, don't worry about them. That would fail to meet the standard and would not create a culturally safe or inclusive environment for your client to receive care. So some of the things that you could do are validating your client's experience. Say, I understand that was harmful. Debriefing the experience with your client, giving them the time to talk about how that made them feel and the impacts on their health. Consider discussing it with the nurse. Like, let's say this is somebody who, you have a good relationship with, and maybe they don't understand the harm. If you have the ability and if you have the capacity to have that conversation, that's another way that you could meet this standard. And if you don't feel like you have, the agency to be able to do that, because as we've said before, we recognize that midwives also work in systems of oppression, and we have to be mindful of that. There are midwifery leaders, there are lead midwives, there are people within these systems who do hold power. And so taking steps to identify and approach an individual in this circumstance to see whether or not some changes can be made, that would also be an example of meeting this standard. All right, making good progress, folks. I'm so glad that you're all still here with me. So caring for clients who face health inequities in ways that remove barriers and support choice. The example here is a client reaches out to the college and states that they were not offered a choice of birthplace. They hoped to deliver out of hospital. However, their midwife was concerned that their history of ankylosing spondylitis puts them at risk of birthing complications. The client reassured the midwife that this chronic illness does not increase these risks and provided the midwife with documentation from their specialist to confirm this. But the midwife is adamant that they do not feel comfortable with this plan. Once again, the College of Midwives is expecting you to work within your scope of practice. And we understand that there are certain chronic illnesses, there are certain aspects of your client's underlying health that may impact the care that you can provide. That being said, the goal of this standard is to remove as many system-based and day-to-day barriers that people who live with, for example, disabilities face so that they can also receive high quality midwifery care. And so in this scenario, there are ways to approach this situation that keeps the client care safe and also provides choice and supports choice for the client. So for example, you can reflect on the lived experience with somebody who lives with a disability. Seek additional information to ensure that you've identified any areas of your own bias. If your natural presumption was, oh, this client has a disability, they're not appropriate for home birth, check that against research, check that against information that is beyond an assumption that you might make. Address this with your client. Communicate in a way that is respectful and demonstrates that you support autonomy and person led care. And again, work with your client to remove barriers which exist that impact their health care.